surgical and prosthetic textbook on basal implantology. He routinely conducts courses in basal and pterygoid implants, zygomatic implants, nerve bypass, and handling complex atrophied cases in flapless immediate load protocols. He practices immediate loading implantology in a state-of-art 6-tier dental practice in Mumbai. He is an ex-mentor of International Foundation and is currently on the panel of International Foundation in Implant Dentistry, Switzerland. The moderator for this session is Dr. Rathod ma'am. Ma'am has completed her BDS and MDS in periodontology from the prestigious Maya Dental College and Hospital, Mumbai. She has more than 23 years of experience as consultant periodontist at various dental clinics across Mumbai and has a successful practice for 18 years. She specializes in advanced periodontal surgeries and implantology. She has a teaching experience of almost 26 years and is currently working as a professor at D.Y. Patil University School of Dentistry, Navi Mumbai. Ma'am is a national level speaker and has been invited as a guest lecturer at various specialty conferences. Dr. Saurabh Prithani is the second mentor. Sir has completed his BDS from TERNA Dental College and MDS in periodontology from Siddhartha Dental College. Currently, he is working with TERNA Dental College as an assistant professor since 2015. He has keen interest in oral implantology and has undertaken research in clinical periodontology. He works as a consultant periodontist at various clinics in Mumbai and has his own successful practice. We welcome him.
Can they set it up? I think so till they are setting it up, let me thank all the organizers who have given me this opportunity to talk to you all. Varsha madam, Dr. Saurabh, thank you for almost playing it out so nicely, where you gave Nitin the difficult role of convincing people that we need to work flapless and with immediate load protocol. So thank you, Dr. Nitin, for doing half of my job. And of course, Deepika madam, again, thank you once again for giving me this opportunity to talk to your doctors. So let this be a bit more interactive, because I understand all of us are sitting over here to learn and implement something. So firstly, I want to know how many of you know about basal implants? How many in this group have at least heard something about basal implants? So I see a lot of people who don't know absolutely about basal implants. The simplest idea of basal implantology, what you can carry from today's lecture, is it is not something new, it is what something already existed. To take one step ahead of this sentence which I just mentioned right now, forget implantology for the next 2-3 minutes and just think about me, think about you placing, let's say, a nail in this wall right now over here. So let's say I want to place a nail over here in this particular board. Would you want this structure over here to be hard, or you want it to be soft? Hard or soft? Hard, of course. We want it to be hard. It means that anywhere where we want to place a fixture, which is in our medical language or what we routinely call as implant, we want to place a fixture, we want that surface to be as hard as possible, or scientifically speaking, as mineralized as possible. Agreed? Agreed? Yes. Okay. Now when we look at any structure in the human body, or any bone for that matter, because we are going to place our implants in the bone. Dr. Nitin already explained, but I request all of you, especially the students who are here, to go through these 2 videos. One of the videos specially mentions about a special instrument called C Finder. I don't want to take time over this, but it's almost like a magical instrument for those who want to enter into pterygoid implants. So just consider watching this video once. And the other is a modified technique. I've learnt a lot about zygomas from Dr. Nitin, but to keep our life simple, we have modified the technique which he normally propagates into just a 2-hole technique. So I will not consume time on it. I will just refer you, just go to my YouTube channel and search for 2-hole zygoma technique and the C Finder, and you will get to see how exactly you can further modify and make this complex procedures easier for you. So with this, I want to also let you know that in this presentation, for those who have heard about basal implants, I am going to burst certain myths about basal implantology as we see along. So this part we already discussed, wherein what is basal implants, why basal implants, and where do we search for basal bone? Is it all clear so far? Yeah, next question. Right? Now, being a one more tip which I can give you, being a MDS oral radiology, having put more than thousands of conventional implant and more than thousands of basal implant, the best X-ray to go for is a OPG X-ray. Especially if you want to study the corticals, and those of you who want to understand this statement further, being an oral radiologist on an open podium, I state this, that the best X-ray is a OPG, and why CBCT misguides you. So those who want to understand this statement, again I have a YouTube video explaining why sometimes the CBCT misguides you. But to tell you in a very nutshell is, all these X-rays are shadow casting, which means that when some light is going over here, the shadow is getting casted. Correct? So the way I hold the light and the way I hold the object will determine how the shadow is casted. Now most of us see the CBCT on those sheets of printout which the radiologist is giving us. Which means the way a technician wants to show you the bone, you are watching it. That is how when Dr. Nitin sir was showing a slide which showed only 3.7 or 2.5 millimeter width, it was not the case, because in reality, as he showed in the video, he put a 4.2 millimeter implant. So all those who want to not allow the CBCT to misguide you, you should be going through the DICOM images. So either you sit with the DICOM images, plan your cases in the angulation of the implant, you will see the correct height and width, or stop using it. The bigger challenge remains, if you sit with the DICOM images, is the way you plan it on the computer, exactly same way you should operate. So I hope you are able to connect the dots and understand what I am trying to say. So if you can design a system which is making your life simple, work with the OPG, have a design of the implant which you know is going to be wide at the apex and your bone is going to resolve and still remain wide at the apex, it solves a lot of problems for us. So these are, you have a laser or something? Okay. Right? So these are the corticals to engage. As I have already mentioned, in the maxilla, the second cortical which we normally engage is a nasal cortical. In the pterygoid area, we have already seen the pterygoid implants, and we will see also the zygoma. In the lower jaw, because we don't want to do any cantilevering, routinely we do what is called as a nerve bypass, which means that instead of grafting above the nerve, we try to place our implants either buccal or lingual to the nerve, which is called as a nerve bypass procedure. One of the simplest procedures for a beginner basal implantology to master is a nerve bypass procedure. One of the simplest procedure for a beginner to start off, which we start off in our courses, is starting a nerve bypass. It is as simple as that. It is just that you have some knowledge of the anatomy, and then definitely you can start off with nerve bypass, and it is easier to master than doing a ridge split or a complicated procedure than a sinus. Right? So these are just the images showing the different areas where the implants can be engaged. And as you see here in the images, you will see a different kind of configuration of this implants. Now, I am right now promoting a system which is a R-line implant system. So the name has been derived from my name, which is R. And categorically now we want to start dividing the implants not into conventional implants or basal implants. We want to start dividing them into single piece implants and two piece implants. So what we mean by single piece implant, where the fixture of the implant, fixture is the part which gets fixed in the bone, and the abutment of the implant are in one piece. That also gives you the advantage of no screw loosening. So all your single piece implants, and then you have a different category of implants where your fixture and abutment are different, which we call routinely as the classical or conventional or the two piece implants. For the sake of simplicity, I am going to focus my lecture right now when I say basal implants as single piece implants, because a lot across these 2 days has already been discussed about the two piece implants. So for the sake of simplicity, I would like to focus and show more regarding the single piece implants. Now when we come to single piece implant, one of the most common debate given by everyone is that if you do a full mouth case with cement written prosthesis, because obviously if you have a single piece implant, you have no other option but to cement your prosthesis over the implant. You can't screw anything on it. The challenges you will feel is retrievability. To counter that, the the single piece implants are also available, as you see, in the screw retain format. So this is the cement retained, and now we also have the screw retained single piece implants. Also, I will show you very soon strategies wherein with the cementable single piece implants also you can create retrievable prosthesis. So this covers the entire spectrum of implantology: single piece, two piece, the single piece cemented, the single piece screw retained, the single piece zygoma, and then you also have the two piece implants with various designs. Now when you come to the single piece implants, this implant, the BCS implant is a completely polished implant. It's a totally smooth surface implant. There is no surface roughening done on this implant, and they are routinely called as BCS implants or bicortical screws. Okay. Yeah, thank you. So these are called as the BCS implants, okay, which are completely highly polished implants. Polished means they are so smooth, you throw it on the floor, you rub it under your feet and put it in the patient's mouth. Don't do it, sir. Some of you are making notes, you are not supposed to do this. I'm just telling you so that it goes in your mind that it is highly polished. Madam, some doctors are making notes. I was worried. Okay, you're not supposed to do this. I'm just telling you for the sake of explanation that they are so highly polished that nothing will stick onto the implants, and they work by property of osteofixation. So when this screw is fixated on this table, I can actually lift the table based on this screw. So it's osteofixated. All these years we have been running after osseointegration, realizing or not realizing the fact rather that even with fixation in the hard mineralized bone, we can go ahead and load our implants, because ultimately implantology is about force diversion. It is never about putting screws in the mouth. As long as your force are getting diversified to your hard mineralized bone, you should be good. Okay. So techniques of placement, again I will skip because that could be a lecture by itself, but again I refer you to my YouTube channel, where I have given all this free content, where any of you who is interested to go deeper into it can just watch this video, drilling protocol. Now coming to the BCS and QS cement retain. So I hope all of you have understood. We are talking about single piece implants, we are talking about cement retain options, and they are primarily divided as smooth surface implants, which we call as the BCS, or bicortical screws. Now why we call them bicortical screws? Because we place them from one cortical till the opposing cortical, and we fixate them in the opposing cortical. So they work on principle of osteofixation, as opposed to your KOS implants. Which are single piece implants but rough surface implants, which means they are also in a single piece. The fixture and the abutment is one piece, but they have been surface roughened like any other conventional implant, and they osseointegrate with the bone. So how they work? They work by osteodensification. When we place these implants with a smaller osteotomy, it is compressing the cancellous bone and creating a fixation over there. So these are the two different types of single piece implants, I will show you all the remaining cases. Okay, we are skipping this part of, which is also according to me a part of basal implants, because this implant also nowadays we engage the opposing cortical, but I am skipping this entire series and we will stick our discussion to the single piece implants. So let me bust some myths and facts about this implantology for all of you. So one of the most commonly heard things is that with single piece implants you cannot achieve aesthetics, but as you see on my slides over here, with good planning and execution you can achieve excellent aesthetics without any bone grafting, without wetting, and sometimes even without zygomatic implants, because these implants will allow you to engage whatever remaining bone is there. So if I'm doing, let's say, a typical 5 full mouth cases in a week. 3 of them will be resolved, wherein we don't do bone grafting. With the conventional implantology, one of them would need a zygoma, but with this we avoid that also. So if I look at the number of zygomas, which also require some degree of invasion into your third cortical opening, the flap can also be avoided simply by the mere change of design. Another myth is that single piece implants do not allow you to do it for a single tooth. That's absolutely not true. Routinely, I have overseas clients who visit my operatory in the morning, take a flight. It's a lower molar, let's say. We place the implants. By afternoon, we have done the scan, got the crown ready, and by evening is ready to go back home. So definitely, single tooth can also be done. It could be a single molar, it could be a single premolar, or any other single tooth, like a central incisor. Another myth commonly said is that the segments cannot be done with the basal implants. But as you see here, we are also able to do segments with this kind of implantology, wherein you see on the top, these are BCS implants. These are BCS implants, all of them. As you see, they are totally smooth surface implants with a thread-like design at the apex. The pterygoid implant engaging the sinus floor, and what is called as a canine bypass, which means we bypass the root of the canine palatally to engage the nasal hole. And in the lower jaw again you can see a segment case which is done with a mixture of compressive as well as BCS implant. Another case showing an upper 7 tooth and a lower full arch case, which means that any case and every case we will be able to do with this different implant design, no matter what is the resorption. All the drilling protocols are normally flapless and a single drill protocol. Now again, the most common myth is that basal implants or single piece implants cannot be temporized. 100% they can be temporized. In fact, it is recommended to temporize all your full mouth cases first, let the things settle down, healing to happen, and then go with the permanent prosthesis like what I am showing you. So here I am showing you the resorption is taken care of, and long-term situations, even for smokers, for diabetic patients, patients prone to osteopenia, all this group of patients are also secured the moment you start thinking about smooth surface implants, आपका BCS implants, आपका basal implants. So that is why this bicortical screws, if you can think about, they will be a game changer in your practice. Here I am showing you another case again with single piece but screw retained designs. So those of you who still want screws in the mouth for retrievability, you see here wherein this single piece implants with the screw retained options are available to help you with the retrievability option. So everything is getting taken care of, wherein you are able to do flapless, immediate loading, create retrievable prosthesis, create the different kind of frameworks what you would like to create. Okay. Another myth lot of people say is that smooth surface implants, they do not integrate. But 100% from my years of experience I can tell you, they can integrate. And if I can make this bold statement over here, it is not required that they integrate because they are already osteofixated. As long as this nail is doing the job over here, who cares what is happening inside between the nail and the wood over here? If you can look at a practical term, this phenomenon that we need osseointegration has been pushed to us. Patient has not come for osseointegration, boss. Patient has come for eating. Patient has come so that he can chew whatever he wants. And as long as you are able to do non-invasive procedures, as long as you are able to keep your mind open, as long as you are going to help the patient in 3, 4, 5 days, skip the entire, that entire way of doing sinus lift, bone graft, bridge splits, patients are happy. And I can tell you from my experience, how many of you have done at least one implant in your life? At least one. Have you seen bone forming over the cover screw? It's as simple as that, because this is also titanium. As long as the bone osteoadapts around the implant it does not have any micro motion, everything is going to sustain. So these are all paradigm shifts which you need to inculcate when you get into this kind of implantology. Okay, and here I show you this case. These are all smooth surface implants. इसमें volume है, volume है. Wherein I am knocking on the implants. Knocking is one of the best ways of checking the crude, but the best way of checking the integration of the implants. These implants have been, the prosthesis has been removed after 1.5 years for change of prosthesis. And unfortunately, I think sound is there. Sound is not there. Otherwise, you would have heard the tapping noise around the implants. Apart from the stability and the X-ray, which shows that these smooth surface implants also are stable. Lot of myths also that if I want to get into basal implantology, literature is not available. So from my end, I have contributed in this community by providing 2 books. One is the surgical book on basal implantology, and other is the prosthetic book on basal implantology. Those of you who are interested to at least review the book or just surf through, the stall is there outside. I invite you to visit our stall as well. Now the next thing is that because these are single piece implants, the digital workflow is not possible. That is also not true, because routinely now we are scanning the implants directly. In fact, it is reverse. You can directly scan these implants without the need of scan bodies. So whatever is actually coming to you as a problem is actually not the problem. The reality is something different, wherein you see these implants can be directly scanned without the need of scan body, which saves you additional armamentarium. Because if you are doing 2-3 cases in a week, you will require that many number of scan bodies, or if you don't require scan bodies, definitely your digital lab analog will start getting locked in the cases. So here you will see that your armamentarium also will come down when you implement this kind of system. A lot of times I have been told that because you are using single piece implants, the prosthetic gets compromised. But I can show you hundreds of such cases where the prosthetic is sometimes even more, I would say, better than your screw retained or classical implants, even though you are not doing any kind of hard and soft tissue grafting. So please do not come, if you come across this kind of situations or this kind of comments, they are totally baseless. Please don't believe them. And nowadays we follow a lot of spill protocol. So spill protocol is another protocol which I have been researching over the past 3.5 years. SPIL stands for simplified, SPIL, simplified protocols in immediate loading, which means that we no longer get into the debate of conventional or basal implants. We just think what is good from the patient point of view, and depending upon what is good for that particular site, we will use either a 2-piece implant or a single piece implant. And to push the boundaries ahead, we even mix those systems, which means you will see my cases coming up wherein I have mixed conventional or 2-piece implants also with the single piece implants. This itself can be another conference by itself, madam, to consider, wherein we are amalgamating 2 different sciences into one science, ultimate aim being to make what is best for the patient, flapless, immediate loading, and no additional procedures. That's the theme we should be carrying home from today. So I once again thank you all for giving me this opportunity, and invite any of you who are further interested in this science to join our upcoming programs. Thank you so much. Easiest for the beginner is to create intraoral welding. So have you heard of intraoral welding, any of you? Intraoral welding basically allows a titanium wire to be fused on your implants. Okay, so when this is happening, the temperature in the mouth can go as high as 10,000 degrees. But of course, patient will not feel anything. That temperature simply permits the titanium ions to fuse with each other. So with this technique of intraoral welding, you are actually fusing a wire, titanium wire, across these implants to create what is called as a bilateral cross-arch stability or rigid fixation. The moment you have done that, your framework is ready in the patient's mouth. Straight away, you have saved 20,000 rupees. Okay, if you want to create a CAD/CAM based screw retained prosthesis from a good lab, you are looking at around 15 to 20,000 rupees. Here you are looking at 500 rupees. So your framework is created in the patient's mouth. Your implants have got stabilized. Anything. Now, if your lab is really good, nowadays we are also making a lot of click-on implants, click-on prosthesis, which means that prosthesis will click in the patient's mouth, remain there. But whenever we want, we can just pull it off. So we have gone one step ahead. No cement, no screw. Now I do not want to present this to all of you because it would have created a lot of confusion. But this is what we have come up to. Wherein our full mouth cases are normally, I have put up one YouTube video, 8 minutes lower full arch. So our full mouth cases are normally 15. So I want to make implantology a OPD basis procedure. Just like you do a central incisor root canal, I think all of us should be doing implants. The idea being the patient should also feel easy and you should also have a simple protocol, single drill, all the cases, and that's how with the intraoral welding you saw over here, we have placed the prosthesis and just clicked it out. Thank you for your patience.
If I have a patient in mandible, I can place an all-on-4 or all-on-6 because the patient has bone, and in maxilla there is atrophy. I mean, what are the considerations you are taking?
Super question. Super. So madam's question is that what about a situation wherein the patient's jaw is resolved, but still she wants to place a all-on-4 in the mandible? That means what you mean by all-on-4? Between the mental foramen, you're placing 4 implants. Okay, this was the weakness. But in the maxilla, for some reason, she wants to consider placing the basal implants. That is what we are coming up to. So my last slide, madam, you picked it. That is what was my purpose of my last slide. That our idea is not to think about conventional versus basal. Our idea is to think what is good for our patients. Correct? We are not against any science. If your patient, definitely if you feel that from whatever workflow, your x-rays or you can do something like that, 100% you should do it. Also, I have come across situations wherein, to take one step ahead from your patient, you place the lower 4. If you are in doubt, you give a hybrid prosthesis. Metal to acrylic prosthesis are called hybrid prosthesis, which creates soft loading, okay, up till here with a shortened dental arch, that is 5 to 5. After a period of integration, you add the basal implants doing a nerve bypass. So let's say you have started with implantology today, you are not an expert, you are scared to do the nerve bypass, you will place 4 implants here, give the patient a shortened dental arch. Over a period of 6 months, 1 year, 1.5 years, as you evolve, you are more confident with the other cases, you think about adding implants posteriorly, nerve bypass, because we don't want to cantilever. In the meantime, with the basal implants, you have already finished the upper arch. So the idea over here is that at no point of time, our patient is without a teeth. We always talk about extraction and immediate implant. A lot of times when you people start doing the private practice, you will realize that a lot of times in the private practice, patients and you are discussing about sinus lift. So you are educating him what is a sinus, what is a bone graft. There is a disparity between what you want to sell and what the patient has come to buy. And then everything trips, because then patient will say soch ke aate and you lose the patient. That is the reality of private practice. But when you make a call right now to my practice also and tell I want teeth, my assistant will tell you we'll give it in 3 days, we'll do it flapless, we'll do this is the cost. It becomes very simple, because for us the protocol is that no matter whatever the case, we are going to do flapless, we are going to load immediately. We are never discussing your sinus is less, your bone is less, all those things we are out of our discussion. That makes your patient management, your conversion very easy. That makes your ROI, return of investment, very easy. And as far as armamentarium is concerned, this is just a single drill, a single kit. The kit is outside if you want to see. Most of the cases single drill. So it's like everything fusing over here, one drill, one system, one religion. So if I may put up, the purpose of my life is Dharam Parivartan. I want to take conventional implantology and get them into basal implantology. Right? Because that is what I feel is good for our patient. Thank you for the patient.
Coming up with a good